Well, welcome back, everyone. Those of you that are still in the lobby or in the food area, come on back into the room. We have a wonderful session to wind up our conference for 2022. Just before we do, I wanted to remind everybody about your forms that you were filling out. What are they called? Evaluation forms. They will be collected on your way out at noon, so at the door. So please do make sure you fill out again these forms, and especially this particular last one. We don't want to leave this one off your form as well. And secondly, this will be the last time you kind of hear from me before I kind of just say goodbye. I wanted to just quickly just mention, if any of you would like to see any of the films I've produced on, or we've produced on euthanasia and some other life issues, please just email me. I'll send you a free link. My company has done media. There's Fatal Flaws, Legalizing Assisted Death, which is takes us to the Netherlands and through the U.S. and Canada. The Euthanasia Deception, which was in Belgium. Fearfully Wonderfully Made, which is a beautiful film that's coming out in January. And one of the films I'm working on right now is Roe, Canada, The True North in a Post-Roe World. Could it happen here? Could a Roe-like decision happen here? So this is the one I'm working on right now. We'll also put this in the final email going out, and just fire me an email. We'll make sure you get a copy of those films and the people that worked with me on them, because it's always a joint project and I never can take full credit, but very happy to do that, and my ministry, Prophets of Hope. So anyway, shameless self-plug there aside, we'll move back to more important and beautiful things. Last night we were introduced to Dr. Sheila Harding, the recipient of the Dr. Paul Adams Award for 2022. So you can already see the kind of person that we're going to hear from in the next session. Sheila was Ross Harding's mother. Ross was born with a rare, unpredictable, life-limiting disorder called Menkes Disease. When Ross died at age 10, he left Sheila, husband Terry, and brother Jamie with more Ross stories than one presentation could begin to tell. What Ross and his family experienced through those 10 years did much to underscore the centrality of accompaniment in the care of those with disabling and or life-limiting conditions. Please welcome to the stage Dr. Sheila Harding.
Thank you. I think I have control. I have a disclaimer statement. I want to say that preparing for this presentation is much more challenging than teaching the coagulation cascade. That I won't be directly addressing the first three objectives in violation of all medical ethical principles, medical education principles, but there isn't actually going to be a test other than real life. And they've already been amply covered this weekend, but I have added a fourth. I have lots of biases, and they will become obvious because I'm talking as mum instead of as that putative, neutral professional. But none of them are of particular concern to our professional institutions. And I cry at supermarket openings and Kraft cheese commercials, so we'll see how this goes, and you'll have to bear with me. The first three objectives are on your little app there, and I'll leave those for you. The one that I've added is to be able to distinguish between compassionate care and compassionate presence, and commit to seeking opportunities to practice compassionate presence in your professional and personal lives. Ross was our younger son. He was 10 years old when he died in 1996. He had a very rare X-linked disorder of copper metabolism called Menkes Disease, which left untreated is uniformly fatal in infancy. The oldest survivor, 10 years older than Ross, was the first to be treated with an experimental drug called copper histidine. Ross received a daily injection of copper histidine from the age of 4 weeks until his death. Although this treatment prevents the neurologic damage that is typical of Menkes disease, it doesn't reverse the substantial problems that these boys have with impaired energy metabolism and defective formation of connective tissues, muscles, ligaments, and such. Bowel and bladder diverticuli are typical. Ross died of complications related to his anomalous urinary tract and his unstable hemodynamics. I don't know if I can go back. I want to take an opportunity to embarrass my husband and just say publicly for the record that I cannot imagine a man in the universe better equipped to have been Ross's dad. So, onward and upward. We still think Ross was a gift to us and the world, and other less biased observers agree with us. He was bright, affectionate, articulate, perceptive, funny, and occasionally prophetic. In his first 6 years, he weathered several life-threatening medical crises. On occasion, a junior pediatric trainee who knew the books but did not yet know the boy questioned the appropriateness of aggressive intervention for a child who's going to be dead soon anyway. Senior trainees simply said, "Ask us that again in 2 or 3 days if you still think it's relevant." It was our experience that anyone who spent time with Ross was quick to join the fan club. The uncertainty of his future just added poignancy to the present. Between the ages of 6 and 9, Ross was almost consistently healthy despite his physical limitations, and many people, doctors, nurses, pharmacists, therapists, teachers, family, coaches, friends, others, worked very hard to help Ross live his best life while he enriched ours. Does anyone here know John Patrick? Show of hands. I have it on good intel that Ross was the first person ever to loan John Patrick a teddy bear. My husband Terry and I learned countless life lessons through being Ross's parents. Terry's an engineer, and as you know, I'm a physician, and so like most of you here, we are action-oriented problem solvers. We learned quickly how to be effective advocates for Ross, and we have innumerable stories of the compassionate care he and we received. Today, in keeping with the theme of the conference and much of what you've already heard, I want to focus on something that took more effort and practice for us, and we more often got wrong: the concept of accompaniment, of compassionate presence. I'll begin with a brief official description, but mostly I want to tell Ross stories that illustrate instances of compassionate presence, with one tale of compassionate care for context and contrast and gratitude. Note that we are a family of faith. Ross grew up into that faith like a flower grows up into sunshine, and that comes through in some of these stories. A quote from Christine Puchalski: "The concept of compassionate presence is relatively new within clinical care. Unlike the term compassion, compassionate presence is a unique subset of compassionate care. It refers to the contemplative aspect of our relationship with patients. While compassionate care can involve empathy, forming connections, helping patients with issues, being respectful, caring, and so forth, compassionate presence calls upon a unique set of skills in which the clinician moves to a more reflective and contemplative space with the patient. Specific communication behaviors for compassionate presence include the practice of deep listening, curious inquiry, perceptive reflections, the use of silence in patient communication, and assessing for spiritual distress." End quote. Now, compassionate presence isn't new at all. What's relatively new is the term itself and the recognition that it has an intentional place in medical care and that there are associated skills to be learned and applied. My personal inner voice shorthand for this has been, "Sheila, your task here is to be, not do. Shut up and listen." My first two examples involve the same incident. On July 1st, 1993, any new residents here? July 1st, when do you not want to get sick? July 1st, 1993, we were awakened by Ross calling out from his bedroom, "Mom, Dad, quick, I have another hole in my bladder." It had happened before with sterile urine, but this time he had just started antibiotics for his most recent urinary tract infection. If his diagnosis was accurate, and it was, he had just spilled infected urine into his pelvis. We headed to the ER and the relevant services kicked into high gear to prepare Ross for surgery. He lay motionless on the gurney, his severe pain untreated as he waited because of his precarious blood pressure. Fast forward to a post-operative conversation with a nurse administering his analgesic. Now note, we had already trained the pediatric nurses well to avoid any messaging that would suggest "poor Ross." As Madeleine L'Engle writes, "No child feels sorry for itself unless some adult is stupid enough to suggest it." She said, "I hear they couldn't give you any pain medicine before your surgery the other day. That must have been tough. How did you bear it?" "I don't know what that means," Ross said, age 6. There followed a brief discussion of what it means to bear something and the distinction between that kind of bear and bear the animal and bear naked. Then came his answer. "How did I bear it? Well, Mummy was there. Daddy was there." Then, giggling, with a twinkle in his eye, he reached down and said, "And Ricky was there. Get it? Get it, Mum? Ricky? Bear it?" Yeah. It was funny, but it was a serious answer. Terry and I were present, helpless to act, yet helping him to bear his pain solely by our presence. We didn't know how long this particular surgery might take. Our pastor and his wife, Rob and Sony, joined us in the waiting room. They brought the giant coffee thermos from the church and a picnic lunch for an army, reading material, and set up camp, prepared to stay for as long as it took. 4.5 hours in, one of the surgeons stepped away from the OR long enough to tell us, happily, that they were just completing a full bladder reconstruction, something we had long discussed, but had never been bold enough to do on an elective basis. It was another couple of hours before we were able to see Ross. Rob and Sony could have dropped off the supplies and left, but they didn't. They stayed and stayed and stayed until the waiting was over, and then they quietly packed up camp and went home. That's compassionate presence. As Ross gained an understanding of his syndrome, he came to understand that his life would be limited, both with respect to what he would be able to do physically and with respect to longevity. We didn't dwell on it, but neither did we avoid speaking the truth as issues arose in response to questions or cues from him. A friend asked a helpful, if difficult, question. "What is your worst fear?" Having articulated that, she asked us, "And if that happens, how will you manage? What will you do?" Once you figure that out, you'll know you can manage anything short of that. Then you can put it on the shelf and get on with living life. That's what we did, and I've used that approach with countless patients over the years. Now, nobody could predict how or for how long life might unfold for Ross. The first metabolic specialist we met advised us to assume no limitations until they presented themselves, and to figure out then what we needed to do. We took that advice to heart, and Ross was fond of teasing me with, "You didn't think I could do that, did you, Mom? You didn't think I could do that, did you, Mom?" Happened countless times. I'm grateful that Terry often gently overcame my tendency to want to put bubble wrap around Ross and helped me to let him experience as much of life as possible. And as has been noted, language matters. Ross hated people saying that he suffered from Menkes disease. "They make it sound like it's the only thing I do," he'd say. He spoke openly about his anticipation of life in heaven, free of pain and illness. It often took unfamiliar adults off guard. After the surgery I just recounted, a colleague from Infectious Diseases came by with his team. Ross said, "They operated on me on Thursday." Yes, they did. It was a holiday, but they couldn't wait until Friday because if they did, then I'd be dead now. "Oh, I'm sure it wasn't as bad as all that," muttered my colleague. Puzzled, Ross turned to me and said, "Oh, well, then what does life-threatening mean?" The consultant quickly excused himself, ushered the team out the door, and left us to answer that one. An instance of compassionate absence, perhaps. I recall another opportunity for practicing my compassionate presence. Ross needed an IV placed, and his anomalous veins made that a challenge. After multiple attempts, he came as close as he ever did to feeling sorry for himself. In tears, he exclaimed, "God didn't make me right." Words failed. All I could do was hold him and wait for him to tell us that he was ready to try again. The next day, feeling better, Ross said, "Do you know what, Mum? None of us gets made right until we get to heaven. I'm just made wrong, different than most people." Indeed. By way of contrast, I want to briefly relate a tale of extraordinary action-oriented, problem-solving, compassionate care. Many of you will know Margaret Cottle, whom you met by video last night. She is a dear friend who practices palliative care in Vancouver. When she heard that Ross was in hospital with poorly controlled pain, Margaret did what Margaret does. She put her own plans on hold, took a version of planes, trains, and automobiles to get to Ross's bedside. She rounded up the pediatric residents and gave them an in-service on the management of acute pain in children, complete with treatment protocols. I don't know if he was the first preschooler to use patient-controlled analgesia in our institution, but it was very effective on that occasion and several others. There are some debts that one can never repay, and that's one of them for us. It wasn't, however, an example of compassionate presence per se, and we can discuss the distinction further later if it isn't clear. When Ross was 7 and Tracy Latimer's death was all over the news here in Saskatchewan, there was a season in which our usually ebullient son was anything but. Quiet, distracted, glum. He shrugged off our attempts to get to the bottom of it. Finally, one day he responded, "It's just that we have to solve the mystery." Mystery? What mystery? "I can't describe it." "Then how can I help you solve it?" "Not you and me, we. God and me, we." Okay, cue the need for compassionate presence. This time it was his teacher's aide who came through with deep listening, curious inquiry, perceptive reflection, and comfortable silence. "I understand you and God have a mystery to solve." "Yes?" "Well, solving mysteries is detective work. Here's a detective's notebook and pen. You can keep it with you, and whenever you find a clue, you write it down in your notebook." He did that for weeks. Then, one day, he was back to his cheerful self. I commented on it and asked, "Does that mean you've solved the mystery?" not really. I just figure God knows the world needs someone like me. Yes, it does. In case you're wondering, we never found the notebook. Perhaps the most amusing incident of compassionate presence, of being, not doing, however briefly, happened in the operating room. Ross needed minor urologic surgery. His surgeon, a secular Jew, told the anesthesiologist he was ready to proceed. Ross said, "Stop! Wait! You have to pray first. I'm not made like everybody else. Only God knows how I'm put together, so you need to ask him for help." We heard this story from the nurse in the OR who knew him well and who reportedly signaled to the surgeon that he had better cooperate. So he asked everyone to bow their heads for a moment of silent prayer. 15 seconds later, the patient was at ease and they were underway. There are many opportunities for compassionate presence in medical practice, some more obvious than others. I encourage you to consider when and how you might be more intentional about using it on occasion in your particular discipline. Consider what Stanley Hauerwas writes in his book, Suffering Presence. The physician's basic pledge is not to cure, but to care through being present to the one in pain. Yet it is not easy to carry out that commitment on a day-to-day basis, for none of us has the resources to see too much pain without that pain hardening us. Without such a hardening, something we sometimes call by the name of professional distance, we fear we will lose the ability to feel at all. Medicine is first of all pledged to be nothing more than a human presence in the face of suffering. To learn how to be present in that way, we need examples. That is, a people who have so learned to embody such a presence in their lives that it has become the marrow of their habits. The church at least claims to be such a community, as it is a group of people called out by a God who we believe is always present to us, both in our sin and in our faithfulness. Because of God's faithfulness, we are supposed to be a people who have learned how to be faithful to one another by our willingness to be present with all our vulnerabilities to one another. For what does our God require of us other than our unfailing presence in the midst of the world's sin and pain? Thus, our willingness to be ill and to ask for help, as well as our willingness to be present with the ill, is no special or extraordinary activity, but a form of the Christian obligation to be present to one another in and out of pain. Thus, medicine needs the church as a resource of the habits and practices necessary to sustain the care of those in pain over the long haul. For it is no easy matter to be with the ill, especially when we cannot do much for them other than simply be present. Our very helplessness too often turns to hate, both toward the one in pain and ourselves, as we despise them for reminding us of our helplessness. Only when we remember that our presence is our doing, when sitting on the ground 7 days saying nothing is what we can do, can we be saved from our fevered and hopeless attempt to control others and our own existence. Of course, to believe that such presence is what we can and should do entails a belief in a presence in and beyond this world, and it's certainly true many today no longer believe in or experience such a presence. If that is the case, then I do wonder if medicine as an activity of presence is possible in a world without God. I want to end my prepared remarks with a story and a poem that Sheila Cassidy includes in her book, Sharing the Darkness. She recounts the story of David, a man in hospice care with a truly gruesome oral cancer, disfiguring, smelly, isolating. She writes, "We wish his suffering could end, and yet alongside this wish, cohabiting peacefully with our distaste, is a real love for this broken man. Like Professor Higgins, we've grown accustomed to his face. We are proud that he feels sufficiently at home with us to leave the room where all the world passes by. People mutter of him as of others, "How awful! If it was a dog, you'd have it put down." True, but then David is not a dog, but a man with cancer in his mouth, who is living out his last precarious days among friends, loved and cherished in a way he has never known before. His is the experience described in this poem by Sidney Carter, the one surprise of being loved. No revolution will come in time to alter this man's life, except the one surprise of being loved. He has no interest in civil rights, neo-Marxism, psychiatry, or any kind of sex. He has only 12 more hours to live, so never mind about a cure for cancer, smoking, leprosy, or osteoarthritis. Over this dead loss to society, you pour your precious ointment, call the bluff and laugh at the fat and clock-faced gravity of our economy. You wash the feet that will not walk tomorrow. Come, levity of love, show him, show me, in this last step of time, eternity, leaping and capering. I've provided some endnotes so people can find the quotes if they wish. And I want to leave you with this as we move into discussion and questions. I'll warn you that Terry warns you through me that for every question I have a story and a quote. So we might be here for a while.
Thank you, Dr. Harding. So much to take in. Compassionate presence. None of us gets made right till we get to heaven. God needs someone like me. Pray, only God knows how I'm put together. Be intentional about compassionate presence. Be intentional. Being faithful can mean being present with the ill, in and out of pain. Medicine can be presence. You wash the feet of those who will not walk tomorrow. Beautiful. Those are the lines that certainly touched me, and I'm sure you have many more. Great. We have a few minutes for some questions, so let's take it to the floor.
Hi, thanks so much for sharing about the story of your son, Ross. It's very clear, based on what you said, that your son had a very deep and personal relationship with his Lord Jesus. And I'm curious as to what practices or what intentional steps you and your husband took. Obviously, that comes from parents, like raising their kids to know their Lord, and I'm just wondering kind of what steps from the beginning you guys would suggest to people who are very, very early on to practice with their families and to prepare for raising strong Christian children.
I might have to get Terry up to the mic. Read. And then as time goes by, you introduce into what you're reading the truths of the faith. Just modeling reading scripture, modeling prayer, modeling church attendance, just building that into the marrow of your life as a family. Certainly, perhaps more than most kids, he experienced adults in his life praying at his bedside. Here's a story. May long weekend, He had been sick as a dog, got admitted to hospital, antibiotics started. The on-call urologist, who didn't know him, walked into the room and saw him sitting up playing video games, looked puzzled, went back out, made sure he was in the right room, right patient, came back, and he said, "You Ross Harding?" "Yeah." "I was told you were really, really sick. You don't look that sick to me." "That's because all mommy and daddy's friends are praying," he said. It was just normal, and perhaps more normal for him because of the acuity of the need on many occasions, that was just more overt. And we don't really get credit for much of it because he took it way further than we did. There was a spot on his bed you couldn't sit because that's Jesus' place. That's where Jesus sits. He didn't have to close the door to his room because his guardian angel filled the door. And that didn't come from us. You know, that was just him. That was all him.
We have a question online. Sometimes we can't be physically present with someone who is sick, for example, on COVID floors. What are some ways that come to Sheila for being present in other ways in people's lives?
I'll start by saying that I think we need to give a serious rethink to how we dealt with COVID isolation. I would have gone berserker if somebody had told me that I couldn't be at his bedside, and I don't know what Terry might have done. And if anybody's heard from John Patrick on this, 50 years later, you don't tell me I can't be at my spouse's bedside as they're dying. So that's an aside. We need to rethink that. But you're right. Sometimes you can't be. Prayer is real, and that would be the first thing. After Ross died, at a time when I couldn't read scripture at all, I just couldn't, my sister committed to praying the Psalms for me, like on my behalf, because I couldn't. And I mean, I didn't know for sure when or what she was doing, but she made me aware that she was doing that, and that was helpful, even though it was at a distance. Just phone calls these days, social media all over the place. We have a good friend whose adult daughter died recently, and I just have a little cue to myself that once a week I send her a text that's just an emoji. And all it is a reach out and touch. She doesn't have to respond to it. She sometimes does. But she knows on an ongoing basis that I'm thinking about her. Use technology. It sounds crass, but put reminders in your phone. If it's not just going to come to mind spontaneously, do whatever it takes. And it doesn't have to be a lot, and it doesn't have to be time consuming. That said, compassionate presence may indeed be very consuming. So those are just some
Nicole.
thoughts.
Thank you. Nicole.
Thank you so much. We hear that medicine can make you tender or it can make you hard. And I can imagine that Ross, in his interactions with medical staff of varying degrees, made them tender. Maybe you could share a story around that. Terry has something to say.
Sure. I mean, you're looking for an example from Ross's story. Diane Comp's quote on the issue is that if you try to distance yourself from the pain, you get all the problems with the pain with nothing in return. They talked yesterday about the reversal of the cleanliness, and there's a reciprocity in the relationship that if you get close, if you risk letting your heart be broken, you'll find it healed. That you have to let it be broken or as bronze, she says. It has to be hard as bronze or broken. But if you let it break, you just might find it healed. The Jewish tradition talks about putting scripture on your heart. They know that we don't have the ability to get it into our hearts. We put it on our hearts, and then when they break, it's there, ready to fall in. So that's another thought. With respect to staff and tenderness of Ross, I imagine the nurse in the OR sort of signaling to this Jewish surgeon that he needed to cooperate. I'm not sure that would have happened if she hadn't encountered Ross a few times before and acquired an affection for him. But she was all on side with helping Ross get what he needed. There's one example that may or may not illustrate what you're looking for, Nicole, but he had been through a series of really difficult stuff. He'd lost about 20% of his body weight. He hadn't been eating and just had no appetite. And then in the middle of the night once, he rang his buzzer like 3 o'clock in the morning, and he never did that. He always just waited for someone to come if he needed something, because he was kind towards them. He wasn't a demanding kid. But there he was on his buzzer at 3 in the morning, and everybody on the ward comes running, because Ross never rings his buzzer. And so he's got 4 nurses in the room, like, what? I really, 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 really need ice cream. And they were so desperate to get calories into him that any other kid, they'd say, wait till morning, kiddo. But this child, they went and got him as much ice cream as he wanted. It was the first calories he'd taken in. In reverse, part of this co-parenting, if you like, there was a day when he was eating his dessert and hadn't eaten anything else. We weren't around, and the nurse said, I'm not sure your parents would be real happy with you eating dessert before you eat, the important stuff. Oh, my mom lets me eat dessert first. Ross, we know your mother. Nice try. But they had that affection for him, and I hope that it opened them up to having that affection for other children as well. I can't say that for sure.
Right, we have about 5 minutes left.
Yeah, thank you again for sharing your story. Just hits harder after being a mom. But yeah, I just appreciate Ross's life, and I just wanted to ask, you talked about compassionate presence, and a little bit about the language that Ross didn't prefer. I think along your journey as parents, what was, I guess from Ross's point of view too, what were some other languages that was used that was helpful, and also language that was used that was helpful / not helpful in your after his death and celebrating his life, grieving the loss, that process with the people who walked through that with you.
Terry may be able to think of specific examples. That's the one phrase that just made him ballistic, suffer from, along with anything that implied that the only important information about him was the nature of his syndrome rather than any of the other things you might want to know about him. So that kind of language, and I was guilty of it myself. I'd been to a women's retreat and came home and what's a retreat, Mom? And what do you do? And he said, oh, so what did you pray? Did you pray for me? I said, of course I prayed for you. Well, what did you pray for? And I went into my list, freedom from pain, freedom from infection, better stability for your joints. And he got increasingly annoyed with me. He didn't quite stamp his little foot, but it was pretty close. And he said, no, Mom, that's just stuff. What I really need is my very own best friend in my very own class. So very often we got so tied up in the medical things, in kind of the life or death things, that we forgot to some extent just about him living his life. Me, perhaps more than Terry. This child with unstable joints and this huge head on this tiny body actually went, what do you call it, in the ring behind the motorboat thing. Like, a friend of ours offered to drive the boat really gently, and we put a life jacket on him, and I put my heart in my mouth, and away he went, and he's hanging on for dear life, but his little thumb is coming up over the edge because he wants Bob to go faster, faster, faster. And the only thing Terry ever vetoed, I wasn't with them at the time, and he knew he would end up in a divorce court, was downhill skiing. And he's saying, yeah, no, that isn't going to happen. But he played soccer, he played lacrosse with his dad, he had a Hopkins jersey, and he was getting new running shoes over his AFOs. And this 19-year-old kid says, oh, Hopkins, you play lacrosse? And Ross stood up and splayed his dislocated elbows and his funny feet, and he said, are you kidding? Look at me, I'd get slaughtered. So he had a pretty sort of clear understanding of his limitations, but we would endeavor to let him do those things. And so it wasn't any specific language that I can think of so much as a way of talking that assumed that Menkes disease was the only important fact and that all these other things about him weren't true. You need to know that Margaret Cottle took that on. She said, no, that the very own best friend in his very own class, that's mine, said Margaret. And so we gave that one to her. And going into grade 5, he came home the first day, and there was a new boy in his class. And he wears AFOs just like me, and he uses big words just like me. And you know, he was just so excited. I said, "That's great, honey. What's his name?" "You have boys, right?" "I don't know." So we figured that out. And for the last few months of his life, he had his very own best friend in his very own class.
Wow, wow, wow. All right, man, I would just like to carry this conversation on. I think everybody in the room would. Well, let's do it. We have another 3 minutes before we go, so let's do that.
Thanks very much, Sheila. You were mentioning that Tracy Latimer, you know, one of the first cases here where people were assessing quality of life and making decisions that, you know, maybe this wasn't useful for them to carry on. Ross was very self-aware. Maybe you could share a little bit with how he interpreted people making decisions for him in his life with respect to what his quality of life was, and was it worth carrying on, and how is he managing with stuff like that?
I didn't bribe him to ask me that question, but there you go. For some weeks, and Terry can jump in if he needs to, for some weeks, from time to time, he would say things like, "Tracy couldn't do such and such, and neither can I." Or, "Tracy couldn't do this, but I can." And he was like creating a list of what they had in common and what the differences were. And we began to understand that he was trying to figure out if there was some threshold that somehow she had fallen under and he had somehow exceeded. But he was giving it some serious thought. I'll tie in a related story. When he first started using patient-controlled analgesia, there was a story on the news about Philip Nietzsche in Australia and the first use of his suicide machine. And I came to his bedside and he was uncomfortable and he didn't have his little pinpoint pupils. And I said, "Push the button." "No, machines like this kill people." And so I unpacked that with him, and he gained comfort in the fact that his machine was not designed for that. You know, that machine was designed to do what it did. This is a different machine that does what it does. And he said, "That guy needed a machine like mine, and then he wouldn't have needed a machine like his."
Wow.
So 7-year-olds get it, right? The way us sophisticated adults don't. So that was his view of that. But he was trying to assess the whole thing. And then one morning over breakfast, he undid us by saying, "Do you know what, Mom, Dad? Next time I get sick, you don't have to kill me, okay? Because I can take it." So here's this child raised in a household where his mom's been writing briefs and all this kind of stuff, who still felt obliged to put on the record, just in case you're not entirely clear. And he used to talk about wanting to be in heaven. You know, he said, "Not yet, sort of not yet. No, I'm not ready for heaven yet." But it worried us a little bit about how that might be misconstrued by somebody who thought that a quick exit to heaven would be a good plan for him. So yeah, there was no avoiding it. We tried for a little while just to not let him hear any of that stuff, and in Saskatchewan there was no avoiding it. So we eventually sorted that out with him, that it didn't matter what level of what, that we would always love him and care for him and would not abandon him. He concluded in all of that, back to your original question, that the most important skill he had that she did not was his ability to speak, and to speak for himself. He said, "They had to guess what she might want. I can tell people what I want. They had to guess what she needed. I can tell people what I need." So he recognized that ability to communicate that for himself directly was a huge benefit to him. And he used it. This is an anesthesia story, Gary, wherever you are. So an anesthesiologist locally with the initials RY was about to anesthetize him, and he was explaining to Ross that he'd put a mask on his face, and he got about that far in his speech, and Ross said, no, not the mask. He was about 6, I think, and Ray said, well, you know, if I don't use the mask, then I'm going to have to use a needle. I'll take the needle, said Ross. He said, well, and he's looking at us, and we're saying, he's had both. Like, he's an informed decision maker here. Is there any medical reason why one is better than the other? Well, no, I just don't like starting IVs on kids when they're awake. And I said, okay, Ross, you need to tell the doctor what you understand about needles. And he looked at him very seriously. He said, I can scream all I want, but I can't move. Those are the deal. And he would. He would make a show of, ow, 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 ow. He was almost kidding. Oh, 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 oh. And then as soon as it was in, he was done. Okay, show over. But that was one instance where he quite clearly knew what he wanted and was an informed decision maker. And so the anesthetist was happy to cooperate with that. He wanted always to know that we knew what was going on. So he needed that kind of parental support. They arrived to take him for an x-ray one day, and we hadn't known that it was happening that day, and so we hadn't warned him, and we weren't there yet. And he just wouldn't go. So they had to phone me, and I had to talk to him on the phone to say that this was okay, and then he was willing to cooperate with it. So he was a pretty good advocate for himself as well. Yeah. I could go on. I won't.
Yeah, we would love to. Thank you. I think all of us come to these conferences. I can't speak for everybody, but I come for strength, you know, to continue fighting the good fight. And I was reminded when you were speaking about when I am weak, then I am strong, and in that weakness, you know. So thank you for sharing today. I think you've given us strength through this incredible story. Thank you for being vulnerable in your incredible profession, which I'm sure you could speak miles and miles on, but this particular story, I think, was so beautiful for today, and perhaps we could show our appreciation. Yeah. Dr. Sheila Harding, thank you very much. God bless. All right, well, we'll move on to our final, I believe it's about 15 minutes of the session here today. This will be the last time you hear from me. Yay! But thank you. It's been an honor to be with you today. I'm very humbled by all of the experience, beautiful stories in the room.